Eric Rutherford is dying of a cancer called myeloma.
It is a cancer of the plasma of the blood. There we go.
And how long's Eric had it for?
6 years.
One of the side effects of myeloma is it wrecks your kidneys, hence the kidney machine, for which we have a love-hate relationship. I love it because it keeps me alive, and I hate being on the damn thing for 4 hours.
And how often are you on it?
3 times a week.
Eric thinks that a drug called Revlimid or lenalidomide will extend his life. But it's so expensive that the NHS hasn't yet decided if we as a nation can afford it. And what's the prognosis?
The only thing left then is Revlimid, lenalidomide. So this is why this nice appraisal is of great interest to us.
That's the last thing I've got.
Do you mean you've got no other treatments?
No, no. Well, what they call palliative care, which means they look after you till you die, which you try and avoid at all costs.
It's September 2008. The NHS's rationing body, known as NICE, is about to begin assessing the drug. Over the next 8 months, I'll follow Eric and Anne as they fight for his life.
Without the lenalidomide, I would give him till about April, May time. I cry all the time, but not in front of him, you know, because sometimes I think it's futile. Then I get angry when he, you know, and I think somebody's got to fight. Fighting, because these are people who don't care. They've got a government remit, and they'll stick to that remit. And it's an absolute disgrace that this government has given a remit to say, oh, we'll save money at any cost.
So what do you worry about?
The suffering that he's going through, that's the first thing. The suffering. And the fear of what he's going to have to go through towards the end. And nobody'll help him. There's only me. And now I'm going to cry. I can't ever imagine being without him, ever.
For the last decade, there have been ferocious battles between patients demanding drugs like Herceptin and the NHS.
We will keep fighting until everybody gets it, including myself, who's been turned down.
This is the first documentary to have access to the institution charged with making these judgments, and to the local NHS managers whose hands are forced by these decisions.
Is it wise to spend £30,000 to get an extra 2 months of life for one person versus what else we could do for £30,000, which might be about having a health visitor, working with some very disadvantaged families, preventing the next baby P?
NICE decides the fate of hundreds of millions of pounds worth of treatments every year. Next on their agenda is Revlimid, and Eric and Anne are going from Doncaster to see what happens.
We don't know what to expect because obviously we've never been before to one of these shindigs, but knowing NICE, it'll be loads and loads of gobbledygook that nobody can understand, only them.
Hopefully. I'm a positive thinker. I always think positive, and I want there to be a positive outcome.
I'm Adam Wishart, a science writer, and I want to meet all the parties in this dispute. I want to discover if it can ever be right to deny a patient a drug for reasons of money alone. It's a story very close to my heart. 7 years ago, my big, strong, vibrant dad fell ill with cancer. For a year, he went in and out of hospitals. He was operated on, irradiated, and pumped full of drugs. And as it was happening, I did everything in my power to keep my childhood hero alive. I argued with his doctors, I met the leading experts and read the research in order to get him the best that the NHS could provide. But for Eric and 1,200 other patients with myeloma, there's a cruel complication that as they worry about their advancing cancer, their survival might hinge on the outcome of a committee meeting that'll happen here at NICE in a few days' time. The story of Revlimid begins with one of the most vilified drugs of the 20th century, thalidomide. It had been prescribed as a sedative for expectant mothers, but it had a devastating impact on their children. A team of university scientists rescued it from the dustbin of history. Then an American company called Celgene brilliantly commercialized it and tweaked it to create Revlimid. Celgene's founder and chief executive is a scientist called Sol Bearer.
I believe our role in society as a corporation and me as an individual, if we cannot, as a company, develop these therapies, then we don't deserve to exist. We don't deserve to have a profit. We don't deserve to do research and development. That's my motivation, making a difference.
There is living proof that Revlimid works. Some myeloma patients took part in a clinical trial funded by Celgene. Julia Gatt is one of them.
I wasn't tired and lethargic all day. I thought, gosh, this is a wonder drug. And I improved so much, it was just unbelievable. But then the trial stopped. They couldn't prescribe it anymore.
And so why is it so important for you to go back onto Revlimid?
It was doing me so much good, and now that I'm on 2 units of blood every week, and the disease is spreading at an enormous rate now, that Revlimid would be able to control it for me.
Julia has applied to her primary care trust in North London for the drug. Whether she gets it depends on NICE. The 1st of October. For months, NICE has been collecting evidence about Revlimid. In a few hours' time, 25 health professionals and lay members will gather here to begin the appraisal. David Barnett is the chair of the NICE committee that will eventually make the decision.
It's an expensive drug. All of the new modern cancer drugs are. And so the committee will be exercised in its decision-making to see whether or not the effectiveness of the drug, as proven by both clinical trials and by other evidence we have, matches up with the price and the cost of the therapy.
The agenda today for committee members, to remind you, is this morning we'll be talking about the use of lenalidomide for multiple myeloma, and this afternoon...
Representing myeloma patients is Michael Brown.
Michael, you've indicated that you don't mind discussing your personal case in public, so do you have any comments on this?
Well, only that I'm on first relapse now, and the opportunity to have... I mean, this is going to come back again, so the opportunity to have something else in the pipeline that will deal with the second relapse is obviously anything that's going to extend my life.
Absolutely.
Excuse me, is very welcome.
Also present is the chief executive of the patient group, Myeloma UK, Eric Lowe.
This guy's been through sheer hell during his relapse for a number of reasons. And I think that it's very important for us to keep firmly focused on this is about patients, absolutely about doing the best for patients. It's a horrible disease, it's not exciting, but for the first time we've got hope.
All agree with you, the trials prove effectiveness, and the safety profile is such, the regulators have done their job. Now we're looking at the real world, what happens today. Eric has pointed out, if you can get paid for first relapse, go for it. The question is...
I really wanted to be in London, but things have overtaken and we just can't get there. We've been advised by our doctor that it's too dangerous for me to travel, so we'll respect his wishes.
We're coming nearly to the end of this, but this section of the meeting.
It seems to me to be within touching distance of what might be considered acceptable. It's tantalising for us as patients and patient representatives that this is a great drug for patients from a patient perspective. And I think it's really important that the people around this table and even the company sit down and get rid of the uncertainties and come together on the assumptions, because it seems to me that we're too close to getting access to a very, very important drug for this to go.
I'm grateful, Eric, that you recognise the importance of the company in this situation, because obviously one thing we haven't and cannot deal with is the price. Eric, as ever, you're a great champion, and thank you very much for coming. Thank you. We'll take a break now. We'll have to go to our part 2 now for the reasons I mentioned before.
Michael's job is done. He can go home.
I don't know how they're going to make the decision, how NICE are going to make the decision, based on what. All I can say as a patient is that any extension of life must be paramount. Well, it is to me. It means the difference between me seeing my grandchildren growing up and not.
Great game. Well done on winning. You need a prize, don't you, really? Yeah. You have to find
Michael is 63. He and his family have lived with the cancer for 5 years.
Well, there's no cure for multiple myeloma, so relapse is inevitable. It will come back. And then it will come back again. So where do I go from here? And the answer is there is another way to go. Well, hopefully there'll be another way to go. And it'll be Revlimid.
We've beaten it once, and our intention is to do the same again.
And how would you feel if they said, you know, that you couldn't have the drug because the NHS can't afford it?
I don't know how to answer that question. I'm devastated, obviously, but I don't know how to answer the question, really.
As the committee reconvenes, I learn that we've all got a price on our heads. But there's a limit. The NHS won't pay more than £30,000 for every extra year that a drug can provide. The manufacturer Celgene claimed that Revlimid will cost less than £25,000, and that would be eminently affordable.
The case has been made by the manufacturer, and the committee have to decide whether they are prepared to accept the case as made by the manufacturer at this stage, and enable us, therefore, to say, yes, we agree with you, or they don't accept this case, and under 2 circumstances. One, the case could be improved if we had some more knowledge of what you've done.
That's where I'm going.
So I kind of minded no. Or we think no matter what you do, this is beyond the pale, it's out of the question.
That's where I'm going.
The calculations are bafflingly complicated and open to interpretation. NICE have analysed the data and what's called the economic model.
What we have done is explored their model. They're not here to criticise our exploration of it. I mean, there's inevitably a non-zero probability that we've done it wrong in some way. It's you know, we do not have ownership of this model. I am not keen. I have to say, I am not keen to acquire ownership of this model.
The committee seems to think that Celgene's analysis overestimates how long people live on Revlimid.
In the company's model of overall survival, what the model says is overall survival does not appear to match very closely the observed data we have from the trials.
And that would mean the company's numbers are optimistic. In NICE's analysis, it'll cost more than £47,000 per extra year, well over the limit.
We need to be pretty clear, and I think everybody is, but it needs to be said, that those numbers, 24,600 and 22,600, are not really based on anything that we can believe, whereas the numbers that go next to them, 47,100 and 43,600, are.
This discussion is just about Revlimid.
Match the Apex trial in both arms.
I think there is a plausible thought experiment.
From where to where? From
What is being implied, and I just only want to make that clear to everyone.
Once we produce the manufacturers...
But similar discussions happen 45 times a year for other drugs.
All of them. They've dealt with the other smaller ones just by putting in a greater...
It's within the current NICE guidelines. The patient lines had some response, maybe.
These judgments could affect any one of us.
I am getting the impression that the majority view is that it would be very difficult at this stage to recommend the use of lenalidomide under any of the circumstances which are proposed. Is there anybody who wishes to disagree with that, other than just emotionally? I mean, emotionally, I'm sorry about it myself, but, you know, I mean, obviously this is an important drug and a very important issue. That's where you are. Any other comments, please? Okay, I think we've done with that one. Thank you very much. We'll now have lunch, and we'll return in half an hour. Thank you. Oh, what just happened is that after considerable discussion of both the effectiveness and the costs of this therapy, the appraisal committee decided that they could not recommend the use of this technology as a cost-effective use of NHS resources.
Today is an interim decision. Now the patients and the manufacturer have 3 months to lay out their arguments before the committee meets again.
Appraisal Committee's preliminary recommendations. Lenalidomide in combination with dexamethasone is not recommended for the treatment of multiple myeloma in people who have received at least one prior therapy.
It's very disturbing actually, because I am at the moment, I'm denied this drug. And if things don't go well with the Velcade, I'm afraid that I've got nowhere else to go.
How does it make you feel?
Oh, I'm always angry. I've always been angry when told that he can't have this and he can't have that and he can't have the other because of cost effectiveness.
It's not for the fact that that said no. It's knowing there's something out there that could help you, and you denied it. That's what hurts. Really, really hurts.
The announcement is very hard on the patients, but thinking about what I've discovered from the document, one detail keeps coming back. The best evidence that there is that on average the drug only delays the disease from progressing for 6 months. So I'm beginning to understand a little more why the committee might have said no to it. I want to meet its driving force, the chair, Professor David Barnett. And I'm surprised to discover that he's a lot more than a bureaucrat. He's a heart consultant in Leicester, making all manner of life and death decisions.
The patient's views of this are understandable because it's their personal problem, but it's blinkered. To assume that actually that would be an appropriate way to run an effective healthcare system within a budget, within a bank account which is a certain size, they wouldn't do that for their own resources. So they look at how much money they're getting from their occupation, and they say, well, I can't afford a Bentley Continental, I can only afford a pitch bike.
But surely decisions about life and death shouldn't be about money.
Life and death is a very emotive term because it sounds like it's an immediate thing. And if you've got someone in front of you who's about to die, you pull out all the stops and do whatever it is, and you don't start worrying about the cost. And if it was me, it was my family, I'd feel the same way. But NICE, and particularly the appraisal's programme, has to stand outside that and look at everybody, not just at the individual. And we are charged with looking after the bank account, if you like, to get value for money for everybody within the NHS as far as is possible.
I'm learning that there are many demands on the £90 billion we spend on the NHS.
It's quite interesting, really. It's 150 grand.
What's 150 grand?
It's an echo scanner for cardiac echo, and its ballpark figure, acquisition cost, is £150,000, which interestingly is about 2 to 3 years worth of treatment for one patient with lenalidomide.
So who actually writes the cheques for the NHS? I've come to North and East Birmingham to meet Sophia Christie, who controls the local NHS budget.
This is a payment for £6,000. That's a little one. I'm hardly spending any money today. I signed the contract for our joint commissioning for £350 million yesterday. I've got to provide life to death universal coverage for 440,000 people, and this year my allocation has been £630 million to do that. The issue is, how do we spend that money wisely? There is a huge amount of trust invested in us by the taxpayer to look after their money and make sure that we can provide good access at the right time for all of those 440,000 people. Now, this particular drug, compared to some of the other things that have been approved, actually, you know, it looks like people might get an extra year or year and a half. But does that compare well with some of the other things we could be doing? When we look at what are the big health issues in Birmingham East and North, they are infant mortality. So we lose about 30 babies a year who would live in other areas of the country. This bit of the patch we're coming into, that men on average are dying 6 years younger than the national average. And so our population, our men in particular, don't really get old enough to get cancer. They die of heart disease in their 50s, 60s and early 70s, whereas in other communities they'd be living into their 70s or 80s and then developing cancer in later life. But we seem to be prioritising a particular group to have access to a level of care and support that is not available to the rest of us.
It's shocking to learn that there are children and old men who could have lived longer if there had been enough money and better services.
Lovely. So it's Thursday next week, UCH. I need a cross-match form, don't I, tomorrow?
Julia's Primary Care Trust have just refused her Revlimid, and one of the reasons is NICE's decision.
Yes. Bye. They've encouraged me to appeal, because I did well on it before.
It seems especially cruel, as she remembers being on the clinical trial.
What is the point of not, prescribing it when it has proved to work? It's not something I'm going to take that we don't know what it's going to do.
It broke my heart. It broke my heart. Unfortunately, yes, it did. It's very, very, very serious thing to say to someone, die, because we can't afford to give you the medicine.
Your husband said that it broke his heart when...
Yes, it did. It did, and the children were very disappointed.
Did it break your heart?
Well, obviously, yes. I want to be around to see my children. You tried to put on a brave face.
Do you feel you're being let down?
Well, they can't care for anybody. That's what my opinion is. They do not care. They're not interested in the people who live in Haringey at all. Too much bureaucracy, in my opinion. We're just numbers to them.
If my dad had needed a drug and the health authorities had refused it, I would have felt just as angry and betrayed. But I'm beginning to understand that this is a choice between high-cost cancer drugs for one group of people or extending the lives of others. With myeloma patients in such desperate need of Revlimid, their lobby is growing. I'm on my way to film at a conference of the patient group Myeloma UK. Their chief executive is Eric Lowe.
Most of you will know that over the last 2 or 3 years, Myeloma UK have become very, very active in campaigning for access to new treatments. And I'm going to ask for your help, because we couldn't have gotten access to Velcade without your help over the last 2 or 3 years. And it actually truly breaks my heart to ask you for help, because you have enough stuff to deal with in your life with myeloma. It's a pretty nasty disease. And then we turn around and say, well, okay, we've got this brilliant new drug, but we can't get access to it. And unless you add fighting and campaigning for that onto your daily to-do list, you're not going to get access to it. That's what happens in this country, and it's so unfair that we should ask you that help us fight for access to a drug that you should really have access to, but that's the way of the world.
When I set off on this journey, I thought this was a story of patients battling bureaucrats. But there is a third party, the drug company. I've been in negotiation with Celgene for months. Eventually, they invite me to America. Reading their annual reports on the way over, I realized that Revlimid has been the making of this once small company in the realization of the American dream. Revlimid first hit the American market in June 2006. In the 15 years until then, Celgene spent $800 million developing Revlimid and 2 other drugs. Now Revlimid alone makes more than $1 billion every year. I can't film in their labs or offices in New Jersey. Instead, I'm invited to a $350 a head gala dinner to celebrate the achievements of Chief Executive Sol Bearer.
We're very honored and appreciative for all the efforts that you've done. Thank you very much.
The event has been organised by a free market think tank who are unashamed of their ideology.
Uncle Sam?
Dr. Sam. Oh, too expensive.
But I thought we had universal care now.
Yeah, government care.
On show tonight is a film which makes fun of governments and institutions like NICE that decide the fate of drugs.
Can I just take my prescription?
No, too expensive, but I got this for you. You can have those.
This is old.
Ah, but cheaper.
Look, this isn't even what my doctor prescribed.
Yeah, but I'm writing the prescriptions now.
When I meet Sol, I want to know why he's charging so much for the drug, even if that means some patients will go without.
This is your seat there.
This is it?
Yeah.
Nice and cozy, just like my living room.
Isn't £50,000 a year in the UK a lot of money?
When you think in abstract terms, but when you think about a drug that will potentially lengthen the life of somebody who is fatally ill, I would submit to you that that's one of the most important things society can spend its money on. Developing a drug is a very, very difficult process from a scientific perspective, from a regulatory perspective. In fact, I've often said it's almost an impossible process. So to encourage that, there needs to be incentive to do that. And the incentive is really the price. The price isn't the cost of the pill. The price is all the effort, the intellectual effort, all the risk you take to get the drug at the end. And then, with the profit that you make on the drug, is that goes into the next drug.
So you're not profiteering from it?
I absolutely not. I think we're very fair, and I think we're doing a service to society, a great service to society in doing that.
To understand more about the drug industry, I've come to Washington, D.C. Merrill Guzner's an expert. He's written a hard-hitting book about how the drug industry makes huge profits.
I do not think the drug companies price based on the investment that they make. They price based on what they think the market will bear. If you read the literature, they actually say themselves, they price for value. So that if you see a drug is going to extend life for 2 years, and you think people are willing to pay $50,000 or $100,000 US for an extra year of life, they will price to the value of the drug, not based on how much they invested in developing the drug, how much they think people will pay for it.
I mean, they've created a blockbuster drug, effectively.
Yes.
Is that fair?
No, I think that the pricing of drugs is really creating a burden for the healthcare systems, not just here in the United States, but all over the world, especially when you get into cancer therapeutics, where even the best drugs have, from a sort of long-term view, marginal effects. You know, a drug that extends life for a year is a great cancer drug. It's not like at the end of the year you're cured. At the end of the year you're dead.
It would be great if all drugs now were much cheaper, but the implications on our children and our grandchildren are profound. But so when governments talk about price controls, they need to remember what are the implications of what we are doing.
And what are those implications?
The implications are that unless there are appropriate incentives, unless there's profit, then new drugs aren't going to be developed.
But they say unless they charge such a high price, like if the price is constrained in any way, then there won't be innovation.
Well, that's the big lie. Medical progress is not about how much money you pour on top of the beaker, and then like a filter, it comes down and out the bottom drips the innovation. That's not how it works. It's about science. It's about public health. It's about the evolution of our understanding of disease as a species and our ability to intervene, which is a joint scientific enterprise in which thousands upon thousands of people and patients are intimately engaged with their hopes, their dreams, and their research. And to say that the only way to do that is through a capital investment model in the private marketplace simply ignores the lessons of history.
As I leave America, I realize the trouble with the price of Revlimid is that there is no clinical alternative. If you're a patient and you've tried every other treatment, then Celgene have a monopoly. And it makes me understand more the need for NICE. It just can't be left to the market to decide if a drug is good value for money. We've come a long way from the innocence of when the NHS was created in 1948.
This new health service will be organised on a national scale as a public responsibility, and so everyone will pay for it.
Thought there was a catch in it.
And everyone will benefit from it. When you're ill, you won't have to pay for treatment, and that goes for the whole family. It's not only to help you when you're ill, but to help to keep you well.
But things have changed since the early days of the NHS. We simply can't afford everything on offer. This is how NICE works. The calculations aren't about the cost, they're about value for money.
But just a minute, where do I come in?
Right here.
NICE's £30,000 limit is what the NHS may spend to provide any one of us with an extra good quality year of life. And in this business, they call that unit of measurement a QALY, a quality adjusted life year. If you're young and eminently curable, you can expect many QALYs from a treatment. So even if it's really expensive, it might be cost effective.
He'll no doubt wish you to see a specialist. They may decide you need special drugs.
But if you're nearing the end of life, through old age or terminal illness, any treatment will provide far fewer QALYs and less value for money. That's why the committee said no to Revlimid, and that's exactly what Eric and Anne think is wrong with NICE.
I've read an awful lot about QALY. I don't agree with hardly any of it, to be honest. So if a person who is terminally ill, their QALY is the same as anybody else's QALY at £30,000. So that means that Eric will have to prove that he will live long enough to say he is cost effective in that. However, a terminally ill person, by definition, doesn't have a QALY. So my argument is, how can it be applied to people who haven't got a quality adjusted life year?
You know that you're going to die, and that drug could have given you another couple of years.
Yeah, but also you've worked all your life, you paid into the system.
Yeah. And, well, as Anne said, you paid into the system. And nowhere did it say until you become really ill and then we can't afford you. You know. I cared about the people who's paid into the system all their life. And then when it comes to the time when they need something back, they're told, well, no, you're too expensive, we can't afford you. That's not... That wasn't the idea of the National Health Service.
Eric and Anne are on their way to a conference of a parliamentary cancer group. It's one of the only places where cancer patients can confront NICE's ultimate authority, the government. The junior health minister with a responsibility for cancer is Anne Keane.
The ambition that we have for our cancer services, the goals set out in the cancer reform strategy, is to make sure that everyone has access to world-class NHS services at every point of the cancer pathway.
Good morning. My name is Anne Rutherford. I'm the wife of a multiple myeloma sufferer. The use of quality-adjusted life year implemented by NICE discriminates against the elderly and those with rarer cancers in our society. I asked the Minister if she supports NICE appraisals where the quality-adjusted life year is unattainable for those in our society who are penalised because of age and disability.
Thank you. My name is Gay Wright. I'm also a myeloma patient. I think my issue really is regarding NICE appraisals. Those of us that have rarer cancers, we are being denied the drugs that we need to keep us alive. I'd like to ask, what is the purpose of NICE?
The purpose of NICE was to do away with the postcode lottery, to some extent the inequalities, and that's why people are addressing inequalities now, perhaps more seriously.
But the Minister hasn't answered my question. So in answer to my question, am I supposed to accept then that you do, Minister, support the use of QALY used by NICE to appraise drugs? Is that what you're saying?
You support QALYs, is the question.
At this particular time, in the framework that we're working with, it is to the forefront of all of our thinking.
So there is chance for reform?
I couldn't say that to you today, Go, because that wouldn't be fair.
Okay.
But what I can say is that at all times, that's a particularly important part of everything to do with that subject area. And I would have personal thoughts on it, which I would feed in to the discussion.
Thank you very much. Thank you.
And the protesting patients do seem to be having an effect. On the 4th of November, Anne Keane's boss, the Health Secretary Alan Johnson, makes a statement to the House.
Statement, Secretary Johnson.
NICE proposes to introduce more flexibility in the evaluation of higher cost drugs, which have been shown to extend the lives of terminally ill patients.
Doesn't this mean that NICE has to be more flexible, so drugs that are now not available on the National Health Service become available?
Yes, it does, Mr Deputy Speaker, it does indeed, because what NICE have seen is that the social, that people care about this aspect of end-of-life care as people are approaching the last years of their life. And they believe that there's a premium that society puts on that that's not reflected in the current systems.
The new rules mean that only for end-of-life drugs like Revlimid, NICE can go above the £30,000 limit per extra life year.
The work of NICE is necessary.
Nobody knows by how much, but the press speculates they might go as high as £70,000.
The principle of this is great, isn't it? The realisation that anything that prolongs life is worthwhile, excellent.
Why should there be this exception?
That's a given, isn't it, surely? It has to be a given, doesn't it? If there's something that can save your life or prolong it, then who wouldn't want it? Who wouldn't agree?
Any increase in the tariff is welcome, and this was so unexpected that it caught us unawares, really. If it helps at least one person, it's worth having.
The new rules take immediate effect, but NICE still has to decide whether Revlimid should be greenlit. It's not a foregone conclusion. And many people hope it won't be, because Alan Johnson may have spun it sweetly, but he's not giving local health managers any extra money to pay for the new drugs they'll be obliged to prescribe under the raised limit.
Once we're operating at that sort of level, it is very difficult to see that NICE will ever be able to not approve anything ever again. So it kind of begs the question, well, what's the point of having NICE? Because if anything, whatever it costs, can be approved, then it would seem to be a bit of a waste of public money to spend lots of time of lots of people even bothering to look at it.
The new rules will cost Sophia up to £3 million a year, money she's earmarked for greater priorities. She's been here before. In the past, NICE have forced her hand.
We'd been through a thought-out process that had included people from our patients group. It had included local doctors and specialists sitting down and looking at 128 proposals that people wanted to see funded, and in the event we only had enough money for the top 15 of those 128, and 3 of the elements which ended up being funded were the 3 cancer drugs, because they'd been NICE approved, and they came number 125, 126 and 127 on the prioritisation framework.
I've come to the Black Country to see the kind of service that Sophia would prefer to spend the money on. Alex Dethridge is a palliative care nurse. Her annual cost to the NHS is a fraction of the price of Revlimid for one patient. But she helps dozens of patients in the months before their deaths.
Do you want your oxygen on?
Because of Alex, 81-year-old Irene Shepherd can choose to come home to die.
It's Friday today, isn't it? So should we give you a call perhaps Tuesday, Wednesday next week? And see how things are going then, because I just want to keep a check on your Oromorph use, so as we can see whether that needs increasing or not.
Yeah.
How would your life be different if this service didn't exist?
I wouldn't. Oh, I don't know what we'd do if this service didn't exist at all.
I think the 4 of us sitting here would safely agree that this is a service that the NHS couldn't do without. I don't see how people like Nan could be without the service of the hospice home help. I mean, I can't imagine what people out there in Nan's situation who's got no family or got no support or nothing, how they get on.
But I would like to say,
Careful.
When the doctor came to see me to give me all the information as to what was going on, and he did ask me if I wanted to stay in hospital or come home. I said I want to come home. I don't want to stay in hospital. I want to be with these.
Being with Irene, I realised just how valuable palliative care can be. But Sophia's plans to expand home support and hospice care could be threatened if drugs like Revlimid go through.
About 4,500 people die each year in my PCT, and at the moment the vast majority of them aren't getting the death that they would prefer to have given the choice.
From the minute I arrived, I got nothing but the best attention that anybody could get.
Fantastic.
And it is a shame that there's not a hell of a lot more places like it.
I hope we keep looking after you well.
They will.
Thank you. Margaret obviously felt quite strongly that this was a better environment for her to be in than an acute hospital bed, which would have been the other alternative, and, you know, she's right.
I can understand Sophia's determination to provide a good death. 6 years ago, my dad had a peaceful and dignified death in a hospice bed like this one. In hindsight, how he died is as important to me and my family as when he died, if when would have only meant a few more painful months.
Where we seem to have got ourselves to on some of these very high-cost end-of-life drugs, though, is a big question as to what value are they really offering. And that's not only a value in terms of population health improvement, but at the individual level, is it always in an individual's best interest to carry on having very toxic substances poured into them in the last 2 months of their lives? Or is that a way of avoiding the issue of actually being at the end of life? And particularly, is it actually preventing them from getting access to the best death they could have?
As I leave Birmingham, I'm troubled by how the increased limit for high-cost cancer drugs at the end of life will affect us all. Surely it can't be right to privilege these drugs above all other services in the NHS. It's January the 6th. It's the first meeting at NICE since the new rules have been announced, and I've heard that some of the committee aren't happy. Revlimid's fate hangs in the balance.
The weight's on your shoulders.
The weight is on the committee's shoulders as a whole. All of them are part of the decision-making process. I just help them with that. I'm the ringmaster.
It's a really big day.
How do you feel?
As I say, I'm strangely nervous. I never get nervous, but I'm nervous today because I think if you look at the history of myeloma in this country for patients, this is a big, big day. You know, there's not that many novel treatments for myeloma. Revlimid is only the second treatment to be licensed for myeloma in about 10 or 15 years. So it's a big day, and the myeloma community will be on tenterhooks for sure.
Where are you going?
And the meeting begins with a surprise. Celgene have offered a new deal. If the NHS pays for the first 2 years of a patient's treatment, then the company will provide free pills thereafter.
We're now here to discuss at our second meeting the use of lenalidomide for the treatment of multiple myeloma.
The deal means that according to NICE, the cost to extend a life by a year using Revlimid has fallen from £47,000 to £43,000.
So the comparisons here are 43,800 versus 30,300. I mean, that's the numbers.
I think the one thing that we're taking here as a given is that the price cap scheme is the price cap scheme that we've been offered. And I just want to, again, just make sure that that is our understanding and that's our remit.
You must make your decision on the basis that that is currently the proposal on offer.
Yes, I see your point, Mark. In other words, could we go back to them and say, how about a little bit more?
If the manufacturers had set the cost of this drug lower, we wouldn't be having this conversation.
Well, needless to say, if it halved the cost, then we wouldn't be even considering it. That's no problem at all, absolutely.
And the patients would get the
Well, you
treatment.
know, if the price is right, we'll go for it. Yes?
That's the bottom line, isn't it?
Absolutely, and this is the point that Mark's making, but at least covertly. Have we gone back to them and said, can you do a better deal?
As you know, we can't
Well, no, we
go
don't,
back
can't
to
we?
the manufacturers
I think
and do that.
what was interesting was that we've got a price cap. It doesn't need a huge increase.
No, we can go
to
back and
shift
say,
it
how about
again.
18 months?
No,
And
it
then
doesn't-
everything
exactly,
else.
it doesn't need a
I
huge
understand.
shift.
But Mark, obviously that's true mathematically, but you're frustrating me slightly. We cannot do that.
No,
the price is the price
I think it was
now.
important to establish that we couldn't.
The government won't allow the committee to negotiate the price downwards. But now, because of the new rules announced by the Minister, they are allowed to exceed the £30,000 limit, as Revlimid is for patients who haven't got long to live.
So that's where you are with it.
So the only thing that takes it, in any case, not just this one, above 30,000, is that they die more quickly. So any life extension in a short remaining life is more valuable, and that's all we've now got to value.
Correct.
Because the 30,000 is for horrible diseases that kill you anyway.
Correct.
The question boils down to this: how much more valuable is 1 year of your life when it comes at the end of your life?
We have accepted that we're looking at £43,000 for quality, so it's a matter of simply saying, what is that ratio? And that ratio will be 1.4. And that's all there is to it. That's just a number.
What the number means is that we rate a month of life for someone in terminal disease 1.5 times as valuable as a month of anybody else's life. That's what it means.
That's correct.
So we must be very clear that that's what it means when we come to decide it.
A 1 month of life for this group of people is valued by us and maybe valued by society. We're testing all that out, perhaps. 1.4 times anybody else.
Talking about here is going beyond one. So we're saying that there are this terminal phase of life, a week in that, a week of extra time at that point is worth more than perfect health.
We could say no today. We're not prepared to accept the waiting, however you want to look at it. Okay, it's not good enough, and therefore
it goes back in the melting pot. We go to all sorts of who knows what happens behind the scenes, and maybe the company will come up with something else. I can't guarantee that, and I can't guarantee it will be easy.
Just wanted to add, I think we're close to a yes, and I think to take a risk and say no in the hope of challenging the company to come back with a better deal is perhaps a risk too far.
The question now, really, the only remaining question is whether we now say yes to the drug. That's the question.
And the proposition is very simple. My proposition is we say yes to this drug and that I believe the multiplier is 1.4. Now, argue me out of it, do what you like about it, but that's on the table. Now, do you want to vote on that or not? Right, done.
And the disease is spreading at an enormous rate now, that Revlimid would be able to control it for me.
Can society afford innovation that is going to be priced at levels where healthcare systems are going to go bankrupt?
The most important thing to me personally is how quickly can we get this drug in to the market.
It means the difference between me seeing my grandchildren growing up and not.
There are 18 votes. You know what I'm going to say? 9 and 9. Get just a second. Guess what? Precisely. I have the casting vote.
Can I remind the chairman that the honourable way of taking the chairman's deciding vote is to vote in the opposite way to the way you decided the first time, to neutralise yourself rather than to give yourself a double vote?
There's nothing left, and if I don't get Revlimid, that's it.
Okay, I've decided my casting vote is yes. We will be recommending this technology. It's the first time it's happened. If you think I'm entirely happy about it, you're wrong. And we have a 5-minute break, and we're going to do the next one. Thank you.
It's 7 o'clock on Friday, the 30th of January. The headlines. Honda has become the latest Japanese company to report a sharp fall in profits, and a drug which extends the lives of cancer patients is to be made available on the NHS after its manufacturer agreed to help with funding.
The NHS Drugs Watchdog has given draft approval to a drug which extends the lives of patients with blood cancer by several years. NICE had initially rejected the drug Revlimid but revised its guidance for England and Wales after the manufacturer offered to share some of the costs.
Thank God, another chance. There is something there for him. Has he got the strength of spirit and has he got the strength of character to endure it all? For me, it's, well, OK, if this doesn't work, we've got Revlimid. Prior to this decision, it was, oh my God, if this doesn't work, he's going to die.
It means that after my transplant, my second transplant, when the myeloma returns, which sadly it will, then I've got another arrow in my quiver and something to fight myeloma for. I mean, the figures have to be believed. It can prolong my life for 2, 3, 4, 5 years.
Oh, over the moon, especially for the people coming along with diseases, you know, it's going to be wonderful. Yes, I don't know how long it will take, but I'm pretty sure, as it's a desperate situation at the moment, to save all the transfusions, they probably will prescribe it straight away.
That's it. We don't have to fight anybody anymore to get this drug that might help me to live another 2 years. And that's the thing. You don't have to fight anybody. You get tired of writing to people. You get tired of writing to MPs. You get tired of writing to NICE or trying to get information from NICE. And to know it's there and available is brilliant.
The decision means that next year 1,200 patients will get the drug. And the NHS will pay Celgene £45 million. But there'll be no new money to pay for it.
I felt angry. I have 30 babies a year dying that wouldn't die in other parts of the country. And essentially what it felt like was a message that said, you shouldn't bother about that. You just need to make sure that the very small number of people who will benefit from this drug, that's the area that we want you to focus on.
In the year of making this film, I've come to realise just how difficult these choices about our healthcare are. But somebody has to make them. And David Barnett and his committee should be allowed to do so. They could be faster, they should be able to negotiate the price of drugs, and they must be free of political meddling. But ultimately, if a drug costs too much money for too little benefit, then the NHS must be allowed to deny it to patients. And that means that some of us might die a little sooner. But it has to be like that, because if we don't control drug prices, then markets will push them even higher, threatening the healthcare for us all. In the meantime, Michael doesn't yet need Revlimid, because he's just had a stem cell transplant. But the drug will be prescribed to Eric when he relapses. And as I'm finishing making this film, I'm called by Julia Gatz's family. Before she could be prescribed Revlimid, her doctors tried another drug. Its side effects were severe. She had to go to hospital.
Unfortunately, there was a mistake made while they tried to put a cannula into the groin, and then they couldn't stop the bleeding, so it's very traumatic, really, for the whole family. They couldn't actually stop Mum bleeding, so it was a case of them continuing to put blood products through, and the dialysis, and Mum was just getting weaker and weaker because her body wasn't able to the blood wasn't clotting at all.
You can see the blood on her neck here. They're pouring out, coming outside. They kept giving blood transfusion, a lot of it.
I just wish that we'd have, as a family, paid for the Revlimid, so that she didn't have to go through what she did on the Velcade.
Very difficult.
The whole family were really upset that she wasn't able to sort of be at home and in peace, and we believe that if she'd have possibly been granted the Revlimid, then, you know, we may not be in the position where we, you know, where I haven't got my mum, my dad hasn't got his wife. You know, that's how we feel about it.
Oh, God, Judy.